This is the next installment of extending health span, bariatric medicine and the surgical approach. So it'd be bariatric surgery. To understand bariatric surgery, we're going to talk about the anatomy of the gut, and we're going to present some case examples of actual people. And these images are representations. I purchased them through Shutterstock. The types of surgery we're going to go through, the complications, and some of the long-term follow-up. So we're going to go through the segments of the GI tract. First question, name the order of the small intestines. 1, 2, and 3. This is a hard one to remember, so I've come up with a little memory aid to help you remember these segments and the sequence of the small bowel. And the answer is the duodenum's first. It's coming off the stomach, connects with the jejunum, and then the ileum. So the duodenum is very high in nutrient absorption, also caloric absorption, of course. The second part is the jejunum right here, kind of the greenish part. And the third part is the ileum. All of these parts of the jejunum and ileum are responsible for the PYY and GLP-1 hormones that promote satiety. Okay, so here's the segment of the entire bowel. Besides the small bowel, which is the duodenum, jejunum, and ileum, the large bowel includes the colon, the sigmoid colon, which looks like an S shape right here, sigmoid colon, and then the rectum. And the way to remember that is the Dow Jones Industrial Average Closing Stock Report. For those financiers in the audience. So the one thing, the A for appendix, it's right near the beginning of the ascending colon. So this right here, the connection between the ileum and the large intestines is called the ileocecal valve. That's one way I remember knowing. As you begin knowing these segments and structures, all of this will become, second nature. But the ileocecal valve is the ileum attaching to the cecum, which is this pouch of the large intestines. Right here, the cecum. So the case presentation today, and again, these are not the real people. But actually, the mother was a very, very close friend of mine. She's at the age 56. She had a BMI of 60, which means she was 360 pounds at 5'2". She already had diabetes and hypertension. And she had the family history of none of her family living beyond the age of 62. In 2005, she underwent gastric bypass surgery. This is where they took a portion of her small intestines and diverted it. So they leave behind this segment of the stomach. They leave that behind, and they leave back the duodenum because you're still getting bile and juices and all that. But it's coming down here and it's rerouting. And the segment of the small bowel that is attached to this small stomach pouch that's created is the jejunum. So in this, the food that you intake is bypassing the duodenum and going directly into the jejunum. And then from there, the jejunum and duodenum connect together and go into the ileum. So this is why it's called a bypass surgery. The other name for this is a Roux-en Y. The term Y is used because it has the shape of a Y. The small bowel is turned into a Y-shaped structure. The surgery is done laparoscopically, which means that they don't make a large abdominal incision and open the abdomen that way. They make these small incisions, put in these scopes, and do it laparoscopically. Unless there's a problem, unless there's difficulty during the surgery, and they do have to do an open laparotomy. This is just a depiction of what a laparoscopy looks like. This surgery, obviously, they're working down here. This is the uterus. They're working down here in the pelvis. But these scopes would just be redirected here if they were working for gastric bypass surgery or surgery in the upper abdomen, like a gallbladder removal. The advantages is huge advantage with decreasing adhesions, because the GI tract will develop adhesions or stickiness, and they'll get kinks and obstructions. And patients also have less time that they need for recovery and to get out of the hospital. These are what adhesions look like. The upper is just a depiction of what these adhesions look like. These, again, happen, they used to happen before laparoscopy, before this minimally invasive type surgery began. And that's when they touch the bowel with even talc containing gloves, or just anything that kind of disrupts the surface of the GI tract can form these scar tissue, and they will make bowel adhesions and cause pain and potentially increase the risk for a kinking of the bowel or bowel obstructions. Other surgical complications from this type of surgery is that they will get strictures, and strictures are narrowing. They happen predominantly where there's suture lines. So they can get these strictures like in the suture line here, where the jejunum and the duodenum attach there. They can have suture line disruption or infection of those areas. They can develop ulcers. Remember, the stomach secretes gastric acid, and so you can get ulcers in the jejunum. And then gallstones, very high percent of people get gallstones. So those are stones that get develop in the gallbladder. And then because of the diversion of the small bowel, you can see a lot of nutritional and vitamin malabsorption. So that has to be addressed in the nutritional supplementation. And then there's bacterial overgrowth, because you change the bowel and diversion and the acidity. And this is a good other visual depiction of the Roux-en-Y gastric bypass surgery, showing how this is the shape of a Y. Okay, so the mother in this image had all of them, and she had multiple surgeries that followed, including gallstone removal or gallbladder removal. She had some other complications with dumping syndrome, and we'll talk about what that is too. All of these were treatable and treated. So 15 years after her surgery, she's now outlived the lifespan of all of her family members. She's got a 150-pound weight loss. And questions we would ask Avis, even though she had all of these complications, we asked her if the surgery was worth it. Would you do it again? And her answer was, yes, I would be dead by now. My sister, who did not have surgery, has lost both her kidneys, and she's on dialysis. Okay, so let's go on to who's a candidate for bypass surgery. or bariatric surgery. People that have a BMI over 40 or people that have a BMI over 35, along with a comorbidity. Comorbidities would include all of these that are listed: sleep apnea, type 2 diabetes, arthritis, reflux disease, hypertension. All of those will improve with weight loss. So they have to have one of these comorbidities. And in the image here showing the illnesses that are associated with obesity: cancers, pancreatitis, gout, arthritis, all of those. Weight loss following gastric bypass surgery. What is the greatest predictor of who will do well? So they've divided into 3 categories. At 1 year, they've lost 80% of their preferred excess body fat, and they're able to maintain. The second year loses it, then regains. And then the third group has a 40% weight loss, and they remain the same. And the answer is, it all comes down to food timing. This was the research with the nearly 280 participants, and they watched them over 6 years. And these are the 3 different categories: the people that maintained their weight loss, the success after a year and then regain, and then those who had a full regain after 6 years. And the study results showed that the single one factor was food timing. Those people that quit eating early in the evening had a significantly better outcome with their gastric bypass surgery. So it made the difference between surgical failure and weight regain. And this was in the Journal of Clinical Nutrition. So another study, 2017, showed that the reason for this is that the microbiome of the gut changes at night. People that eat late at night are actually feeding their Firmicutes bacteria, that type of gut bacteria. And Firmicutes are very efficient energy harvesters. And so they love being fed late at night, and they absorb all those calories into your bloodstream and increase fat deposition where you don't want it, which is around your middle. Let's go through the physiology a little bit more in detail. So we've talked about the anatomical changes, how everything is rerouted, adding this little gastric pouch. So the food goes into the gastric pouch, and then immediately it goes into the jejunum, that second portion of the small bowel. So food is coming through those red arrows. Digestive juices are coming into it through the green arrows. So you haven't lost your digestive juices. You're still getting your pancreatic juices and your bile from your gallbladder and liver. With the changing of the anatomical structures, name a possible mechanism to explain why gastric bypass causes weight loss. Is it malabsorption, loss of appetite because you've bypassed a large part of the stomach? Is there an increase in GLP-1, the satiety hormone, change in the gut microbiome, or all? And the answer is all of those things are happening. Lots of stuff is happening with the changes of the rerouting of the gut. So just to show you, if you put these side by side, anatomy and physiology, the small bowel that you're diverting away from absorbs a lot of the nutrients and calories. And so that's what we're rerouting around, is the absorption of the tremendous amount of calories, but also stimulating the jejunum right from the get-go. So satiety is very quick. So the stomach size is reduced, the duodenum is bypassed, there's a malabsorption of calories, and weight loss ensues. So remember, this is a review of the hormones. Ghrelin is produced by the stomach, your hunger hormone. And making the stomach smaller, you're not getting as much ghrelin released. Now, the stomach is not completely removed, but the majority of ghrelin is produced in this upper part of the stomach. And as that upper part of the stomach is made smaller with this pouch, you get inhibition of continuous ghrelin release. So you get satiation more quickly. You can eat small portions and you don't feel hungry anymore. The other thing, PYY, GLP-1 is produced through the small bowel, and of course, insulin produced by the pancreas. Following bariatric surgery, the ghrelin levels drop, and GLP-1 and PYY are increased as food is quickly fed into the jejunum. The microbiota. So this is some studies looking at how the microbiota change. They take the fecal transplant. So you take feces from this first individual who's had no gastric bypass and is obese, and transplant into these sterile mice. And the mice develop obesity. Patients that have had gastric bypass have a change of their microbiome. And this is a gastric bypass. This is a gastric banding. In both of these situations, fecal transplants will change the microbiome. Particularly this gastric bypass is the most effective at changing the microbiome. Immediately after surgery, patients will be taken off their type 2 diabetic medications. Immediately, they're told to leave their diabetic medications at home. So without weight loss yet, so they have not lost any weight loss, they just barely had surgery, how is it possible that they don't need their type 2 diabetic medications immediately after surgery? The answer is the famous GLP-1 PYY. Those hormones are responsible for insulin sensitivity. So they change their microbiome, it becomes less inflammatory, and the blood glucose levels start returning to normal, even without weight loss. Let's look at the daughter. This is the daughter on the right. And it's not the actual daughter, but it's a depiction of the daughter from mom. Now, she was 25. She had a BMI of 55. She was the one who initially wanted surgical treatment for her excess adipose tissue. Again, remember, she has a big family history: diabetes, hypertension, early death. Nobody lived beyond 62. And she specifically had no comorbidity. She didn't have hypertension, diabetes. She just had a BMI that was 55, whereas the preferred BMI is around 25, or at least less than 30. So with a BMI of 55, would she be a surgical candidate? And this is the earlier slide, and I just put a little red dot over this. So she has no comorbidities. What is the BMI chosen for patients to be candidates for bypass surgery? The answer is she is definitely a candidate. The answer for this is a BMI over 40 allows you to be a surgical candidate. So BMI over 40, and she has a BMI of 55. Why would we do surgery on someone this young without comorbidities? Because her body is developing inflammation. maybe not noticed with hypertension or diabetes. That hasn't developed yet, but that's coming. So it's hopefully to prevent these comorbidities from developing. At this time, they had decided to do a lap banding. She had not had a baby yet. She wanted children. So they thought she was too young for the gastric bypass surgery. So they did this lap banding. It's an adjustable band, and they have an access port that goes under the skin. You can take a needle and inject this access port and make the band smaller, or take out some of the injected solution to let the band get larger. So it's got a pouch with this adjustable band. So of all of them, gastric bypass surgeries, this is the least aggressive. And of course, removable. Okay, so what she remembers is that she was hungry all the time after she had the 2009 surgery, and she's wondering why she did it. So why did she have all these thoughts after her surgery? Was it their stomach ghrelin still being produced? She's having no changes of her gut hormones, GLP-1 or PYY, or both? And the answer is both. So her journey for the next 4 years after her banding is she lost 170 pounds. For the first time, she could buy clothes off the rack. She became a Zumba instructor, and she got married. Sadly, though, 1 year later, this is 5 years after her gastric banding, she becomes very despondent. Her weight is rising. She's had multiple diets, boot camps. She's paid for herbal injections. She develops bulimia, and which is forced vomiting. She develops a band erosion, band dysfunction, and she has to have the band removed. At that time, she had a surgical revision, and I quite honestly don't know the name of that, of exactly what type of revision. I don't have those records. So this is her journey. Before surgery, she was 360 pounds. 4 years after surgery, she'd lost 190. And 10 years later, she'd lost 240. So you could definitely say that she is not a failure patient. She still lost 120 pounds, 10 years follow-up from what she was before. But in the meantime, what could have been done differently to help her? Could it have been professional help, dietitian, counselor, medications, or both? Answer is both. Remember that the treatment for morbid obesity is for life. It is a stepwise additive approach that begins with that self-directed lifestyle, then goes on to professionally directed lifestyle that includes counselors, nutritionists, sometimes psychiatrists or psychologists. Then the addition of medications, but not doing one without the other. So this is stepwise. Everything is included. And then beyond the medications, then it's added the weight loss surgery. So even though someone has weight loss surgery, they should still be including looking at medications if their weight is not as where they need it to be. Their weight is greater than a BMI of 30, for instance. They still should be seeing counselors, nutritionists, and keeping on with their self-directed lifestyle. This is showing the 3 different forms, or an example of, there's a couple others since this, but gastric banding is what she had. And then beyond that, beyond the gastric banding, is called a gastric sleeve, where they create a stomach about the size of a banana. And then, of course, the next most aggressive approach is the gastric bypass, the surgery that her mother had. So would she have felt less hunger if she'd had the gastric sleeve? The answer is most likely yes. Definitely, if she'd had the gastric bypass, she would have not had those hunger cues. Looking at the results, the success after the different types of gastric bypass surgery, this has been over actually a 20-year follow-up for these different types of surgery, showing that gastric GBP, gastric bypass, has by far the greatest surgical success. And then no surgery, of course, looking at the control. So a huge difference in weight change. Bandings 14%, sleeves 20%. So the Roux-en-Y still has the greatest success rate. Let's get into complications now. After bariatric surgery, how long should a patient be followed? And this is shown an image of how they can develop strictures, vitamin deficiencies, the dumping syndrome that we'll get into, gallstones, and of course, regain of weight. And the answer is, this is a medical condition that has to be addressed for life. After bariatric surgery, there's immediate and there's long-term complications. We mentioned some of the complications like the intestinal obstructions, strictures, and then the non-surgical are the gastric dumping syndrome and the vitamin and nutritional deficiency, vitamin mineral deficiencies. Medical scenario. So your uncle's had a gastric bypass a couple months ago. He really wants to eat that sandwich. So great big hoagie sandwich, lots of bread. 30 minutes later, he starts feeling awful. He develops sweating, feels terrible, getting crampy abdominal pain. So which part of the intestines has been stimulated by this high carbohydrate load? This is just a question asking you if you remember the name of this segment of small bowel that's attached to that small pouch of the stomach. The answer is the jejunum. So it's getting this massive load of carbohydrates. This is called dumping syndrome. And now you can have dumping syndrome without gastric bypass surgery, as it gets dumped into the duodenum. But in gastric bypass surgery, it's being dumped into the jejunum. It's very common after bariatric surgery. So patients and caregivers need to know what's going on and what the physiology behind this. So as the large carbohydrate load hits a small bowel, it stimulates the pancreas to start releasing lots of insulin. And the insulin is overly released, and patients actually get hypoglycemia. And that hypoglycemia, or low blood sugar, is what causes the sweating. So that's just a good thing for you to know with anybody who runs rescue squad. If you see somebody, they're acting confused, dizzy, feeling terrible, and they've got profuse sweating, first thing you do is check their blood glucose level. The treatment for this is making sure that you don't start drinking a lot of liquids 30 minutes, up to 30 minutes after you've had a meal, so that doesn't allow all the carbohydrates to immediately get pushed down into the jejunum. Also, having small meals and avoiding these simple carbohydrates, instead adding more proteins and fat to meals to slow that absorption. Has some more complications. I wrote in all these different parts of the bowel that are responsible for vitamin and mineral absorption. You can see it's all in these segments of bowel. The duodenum in particular is responsible for a lot of the absorption of these major B vitamins and minerals. So when that area is being bypassed, think about what deficiencies may develop. And this is one, vitamin B1 or thiamine deficiency. This was most commonly seen in patients with chronic alcoholism and severe malnutrition. They develop oculomotor, which means their eyes kind of go off in different directions. Confusion, so people misinterpret the confusion from the vitamin deficiency for being intoxicated. So now it's seen more and more with gastric bypass patients as well. And of course, the treatment is replenish the B vitamins, all of the B1 vitamins, including thiamine. So the supplement recommendations are a multivitamin supplement that has iron, and of course the B vitamins. So the way I remember this for supplementing patients that have had gastric bypass surgery is tell them to be strong. So the B vitamins, specifically B1, B12, B9, and then iron is the barbell. So the bottom line, that's what we need to talk about. Why would a person accept all the risks and complications for bypass surgery? And the answer is to live longer. And the studies have looked at this. The mortality rates, looking at cohort studies of people who have surgery and people who do not have surgery. So these are 10,000 patients that are followed over 12 years. The results are showing that the people who have surgery live twice as long. This is the years after surgery. So at 10 years out, people that did not have surgery, 24% of that group died. Of the surgical group, 14%. So surgical patients are able to cut their risk of dying by half, even with the risk of gastric bypass surgery. So in summary, we went through the anatomy of the gut. You learned the mnemonic for remembering the segments of the bowel and the types of surgery. This is showing the Roux-en-Y. The complications, we talked about several complications that can happen, and the long-term follow-up. The candidacy, BMI greater than 40 or BMI greater than 35 with comorbidity. And the importance of these long-term follow-ups with nutritionists, physicians, PAs, physical therapists, counselors. All of these care providers will need to know how to manage patients that have had gastric bypass surgery. Any questions, please leave comments. The PDF and the link is included in the comments